Good evening, everyone, and welcome. My name is Kathy Flynn, and on behalf of the American Liver Foundation, it is my pleasure to welcome you to this professional education webinar, Session 2, Case Studies in the Multidisciplinary Management of HCC. Thank you to those of you who participated in the first session in early February on liver cancer epidemiology and surveillance. I hope you find this evening's webinar highly interesting and relevant to your work. I encourage you to fully participate in the discussions. I thank you for joining us. And now Donna Shaka, the Connecticut Division's Community Outreach and Education Manager, will now take over and introduce our speakers.
Thank you, Kathy. I'd like to introduce our speakers for the evening. We have Dr. Mario Strazabasco, who is the director of the Smilo Liver Cancer Program. Dr. Strazabasco holds an appointment as Professor of Medicine, Digestive Diseases at Yale School of Medicine and as Deputy Director of the Yale Liver Center. With expertise in hepatology, Dr. Strazabasco is an expert in the care of patients with liver cancer. As leader of the Liver Cancer Program at Smilo Cancer Hospital, Dr. Strazabasco coordinates the efforts of a multidisciplinary team that includes medical oncology, interventional radiology, surgical oncology, hepatology, and transplantation surgery. He is internationally known for his work in hepatology and liver transplantation and previously served as medical director of hepatology at Yale. Dr. Strazabasco is a recipient of NIH funding and is a member of several scientific societies in Europe and in the United States. Dr. Strazabasco is also a member of the American Liver Foundation Connecticut Division Medical Advisory Committee. Dr. Tamar Taddy is Director of the Liver Cancer Program at VA Connecticut Healthcare System and Associate Professor of Medicine in the section of Digestive Diseases at Yale School of Medicine. She directs the VA New England Regional Liver Tumor Board, encompassing Connecticut, Rhode Island, and Southern Massachusetts. Dr. Taddy has developed innovative technologies within the Veterans Health Administration for the detection, surveillance, and longitudinal follow-up of patients with cirrhosis and liver cancer. She leads the VA Connecticut's Patient Safety Center of Inquiry, project funded by the VA National Center for Patient Safety, to facilitate early detection of cancer and timely access to comprehensive cancer care through innovation in systems of care and technology. Dr. Taddy is a fellow of American Association for the Study of the Liver Diseases and the American Gastroenterological Society. She is also the Board of Director President for the American Liver Foundation's Connecticut Division and the American Liver Foundation's Medical Advisory Committee member. I just want to briefly go over the agenda for the evening. This is not going to be interactive verbally. The presenters will give their presentations. If you should have comments, you can enter them into the chat box that you'll see on the right-hand side of your screen. The presenters will give their talks, and we will follow with an audience Q&A with the speakers. With that, I'll turn it over to Dr. Taddy.
Hi, everyone. This is Tamar Taddy, and with me is Mario Strazabasco. I just want to confirm that you can see my slides.
Yes.
Wonderful. All right, so this is session 2. We're going to be discussing case studies in the multidisciplinary management of HCC. In session 1, we went over epidemiology and surveillance for HCC, and so now we're moving ahead to really how to perform proper staging and how to discuss these cases in a way that allows the provider to have a cogent plan of care. So the objectives are for you to learn about the complexities of HCC and how to foster a multidisciplinary approach to patient care, to understand the controversies in managing HCC and the unique opportunities that arise from controversy, and to understand the different stakeholders involved and their motivations. So there are many challenges in HCC. It's the only solid organ malignancy that can be diagnosed by radiographic imaging alone. The cancer arises 90% of the time in a diseased organ because 90% of patients have cirrhosis at the time of diagnosis. And that makes disease-free survival relative because the question is, are you having symptoms and short, basically diminished survival based on liver failure or on the cancer itself. And that same problem holds for time to symptomatic progression, because are you having symptoms related to your underlying liver disease or to the cancer? And furthermore, these tumors don't really shrink. So the things that govern response to therapy in other cancers really aren't applicable in a setting of HCC. So, taking a practical approach, should we get tissue? And hopefully by the end of this presentation, you'll sort of know when it's really important to do a biopsy. How do you stage? And does staging allow you to provide prognostication to the patient? What system do you use? And really, can you find a treatment that's befitting of not only the tumor, but the patient's underlying liver disease? And really, which service knows best in terms of arriving at those decisions? When it comes to diagnosis, if you have a focal mass over 1 centimeter, all you really need is one dynamic contrast-enhanced multiphased image that shows the pathognomonic characteristic of HCC, which is brisk arterial enhancement and portal venous washout, and depending upon what criteria you use, the presence of a pseudocapsule. Anybody who has atypical imaging, especially patients who don't have cirrhosis, the onus is on us to obtain a biopsy, because there are other primary malignancies of the liver. And certainly most tumors in the liver in the general population are if they're malignant, they're going to be metastases. So you really do have to rule out a different tumor if you have atypical imaging or if you have a patient who's not cirrhotic. A negative biopsy does not rule out malignancy, especially in small lesions, because the liver is a big organ and small lesions can be missed on biopsy. And nodules less than 1 centimeter, really you can follow with 3-month imaging, and you can even follow with ultrasound if they're that small to look for growth or change. We do a lot of dynamic imaging in the U.S. When really much of imaging for lesions under 1 centimeter can be done with serial ultrasound. So these are the AASLD guidelines for diagnosis. This is sort of the pictorial representation of what I just went over. And this is taken from the 2011 guidelines. These guidelines were revised and they were published just recently in Hepatology. And I should note that there is a caveat on the latest guidelines that basically says, really biopsy should be considered on a case-by-case basis in a very individualized discussion. And that's something that's important. When you do a biopsy, you should be thinking very carefully about what's the downstream treatment plan for the patient, and will biopsy affect that plan, especially if you're worried about seeding and the patient's a transplant patient. And we'll talk a little bit more about that in a case further down the line. So when it comes to staging, really the question is, who are you? So what stripes do you wear? If you're a hepatologist, you're going to be governed by the AASLD criteria and the Barcelona staging classification. If you're an oncologist, you're going to be looking at HCC 7 staging, which is the typical TNM staging, which is also what pathologists use, and they're actually bound by synoptic staging to use this criteria. Radiologists will often use LIRADS or OPTN criteria if they're at a transplant center. Surgeons, if they're transplant surgeons, will use the United Network for Organ Sharing and the Organ Procurement and Transplant Network criteria, or more extended criteria like the UCSF criteria. And if you're a surgical oncologist, you're probably going to be using NCCN criteria. So really you have to be sure you're speaking the same language to the person that you're talking to, because these staging criteria, a T1 or T2 lesion can be very different between criteria. So it's very important that when you discuss these cases, you discuss very frankly which criteria you're using to stage the patient. Now, HCC is not rocket science. A lot of the factors that determine prognosis are just the same as you'd find in any other cancer. So you would be worrying about things like vascular invasion and extrahepatic spread. These things are game changers. They take surgery and transplantation off the table as options for therapy. But things like size of tumor, number of tumor, and location is very important when it comes to liver cancer. Anatomy is key to determining technical feasibility of resection, particularly in the liver. As you may recall from anatomy, the liver has 8 segments. Each segment has its own artery, vein, and biliary tree. And in order to actually take a tumor out, you need to plan very carefully in terms of how many segments you're going to be removing and how big a resection that's going to be. So it's extremely important to plan and have a surgeon at the table when you're discussing these cases. Now, liver function is clearly the principal driver of treatment decisions. As I said earlier, 90% of patients are going to have cirrhosis at the time of diagnosis of HCC, and that's really the hepatologist's duty to properly risk stratify patients for treatments and make sure that we are assigning the proper treatment to a patient whose liver can handle that treatment. And there are other things, obviously we deal with very comorbid patients. We have an older patient population. And so what's the overall patient's health and performance status? And there are a couple different performance status measures we can use. The ECOG performance status, which is an oncologic performance status, and the Karnofsky score, which is the performance status used in transplant settings. Bottom line is if your patient has congestive heart failure and can't walk up a flight of stairs, you probably shouldn't be talking about treating their tumor. They probably have other problems that are more pressing. So fitting that treatment to the patient and their overall health status and performance, as well as tumor burden and liver function, is very important. Now, there's no one universally accepted staging system. As I said, there's a bunch in use, and I gave you some acronyms, but really there's more than 10 staging systems in use across the world. Many, including the AASLD, have adopted the BCLC staging classification, and it's been widely validated in multiple different types of populations. It has 5 stages with different variables like tumor stage, physical and liver functional status, and cancer-related symptoms. And it provides a treatment algorithm. So it's not just saying, okay, what stage are you, but it actually gives the clinician some guidance on what treatments should be followed. So this is what it looks like. And you start with an HCC. And before you even start counting tumors or their size, you actually look at the patient's Child-Pugh score. And this is really important. We tend to get very excited about what we see on imaging. But this tells you take a step back and look at the patient and how is their liver function. So first we look at Child-Pugh score, then we look at performance status, and then we begin to count. How many tumors do we see? How big are they? Do you have vascular invasion or do you have metastases? And this is how you begin to stage a person from very early stage to end stage. Now, the important branch points here is in the very early stage and early stage HCC, where you have curative possibilities. So in a person who has very early stage, you really should be thinking about resection in the patient who does not have portal hypertension or hyperbilirubinemia. And then for patients who have liver disease that's significant with portal hypertension or with hyperbilirubinemia, you really need to be thinking about liver transplantation in these folks and local curative therapy such as ablation. As you get into more intermediate and advanced stages, then you're really looking at other treatments like local regional therapy transarterially, and then into advanced stages, you're looking at sorafenib or systemic therapy. Now, you should know that there is a newer staging system out. It's called the Hong Kong staging classification. And this classification just further breaks down the intermediate stage B patients and C patients. So there are some emerging studies that would suggest that people who have branch portal vein invasion may still benefit from local regional therapy, but this has not been adopted widely. So this really is the staging system that's most in use. And at the bottom, you see some suggestions on, who should be curative at the time of presentation, who should be enrolled in randomized controlled trials, et cetera. So when we're making decisions about patient care, you really have to think about the endpoint. So obviously improving survival is the oncologic gold standard, right? But survival in a patient with liver disease is relative. And so again, it's up to us to perform proper selection and risk assessment. The standard of care is a moving target. There are variations among disciplines, and there are variations among programs and even regions of the country. And so you might ask, well, how do we identify optimal candidates for particular therapies? How do we identify contraindications? And will what we do now affect what we can do in the future? And that's actually a very important question. And no one person really answers this. We sit together and answer it collectively in a tumor board. So having set the stage, I'm going to turn the mic over to Dr. Strasabasco, who's going to tell you about tumor boards, because he certainly taught me all I know about tumor boards, and here he is.
Thank you, Tamar. I'd like to start from the last statement from Tamar that I think is a very important one. What we do now when we first see a patient will reverberate in the future, will dictate what we will be doing after. A typical example is a patient that may be transplantable eventually, and how we address the first time we see this patient is very important, because we may or may not go down a pathway that may prevent a transplant in the future. So every patient is a very complex case, and we need to take into account not only what we do now, but what we'll be doing in the future. And this is actually really too much for a single provider. And given the multidisciplinary nature of the current treatment of HCC, the only way to come up with a plan that is really in the interest of the patient is to gather all these specialists around the table. And this is what is the tumor board is about. You see in this slide how different disciplines actually interact together and seamlessly go from one to the other. There are several people that we need around the table, starting with radiology and pathology that are determinant to stage the tumor and to see his feature, to the hepatologist, which is the person that takes care of the cirrhosis, but also, as Tamar said, of the staging of the tumor, and will follow the patient after the treatment. And the oncology, because oncology brings not only the medical treatment, but also several other expertise and skills that go with the oncology, like treatment of patient in their terminal phases, but also social worker and access to several facilities and possibility for care. And then the surgeons, some places like Yale has both surgical oncology and transplant surgery. And all of these specialists can get referral of the patient. So one important thing is that the patient comes to a single line of referral and is then discussed at the tumor board. And I didn't mention, but it's actually very important, the interventional radiology specialty. Actually, nowadays, between 40 and 50% of our patients are actually treated with local regional treatment. So all these people are actually gathered together around the table with the moderator, and this tumor board is not just conferences, but they are built in a way that they satisfy several criteria. Must be accredited by the College of Surgeons. They must have a mandatory attendance of the people that you see here. There has to be at least one of them each time the tumor board gathers. There's the liaison with the tumor registrar and institutional guidelines in order to go through a quick discussion. We usually at Yale in the tumor board that Tamar has set up, we discuss between 13 and 15 cases. So the discussion is really pretty intense, and a lot of the discussion has to be implied because we use a common language and we have agreed upon a common structure of the way we treat this patient and the way we developed it. Okay, so let's again reiterate what is a tumor board review. Okay, there is a very specific definition that the NCI adopts. So it's a treatment planning approach in which a number of doctors or specialists that are experts in different disciplines review and discuss the medical condition and treatment option of a patient. It has to be, again, accredited by the American College of Surgeons, and there is an oversee by an institutional cancer committee that is built in the Smilo or in the cancer center structure. And mandatory for the discussion are a review of the stage of the tumor and a viable clinical trial. And so it follows a very strict guidelines. So again, why are we having a tumor board? Well, there's several reasons beyond the primary function, which is to make sure that the appropriate tests, treatment option, and recommendation are generated for each patient. This is the primary endpoint, and I think Tamar did a great job in showing you how many different variables we need to take into account, how many different staging systems, how many different ways to look at this problem depending on where you come from. You will use different staging system, you will use different tests, and so it is very important that this is analyzed from every single point of view. And this is what is in a best benefit of the patient, that he has an approach which is actually commonly accepted by all the different specialists. But there are also secondary functions, which is very important, and that basically helps the program to grow. Because in the discussion that we have every week, everybody contributes, like maybe a sound bite, just a 2 cents of sound advice, or the last paper that he or she has read. So this is like an accrual of small components, but by doing this every week, every time, there's a common growth. It's also helped us in reviewing the outcome of what we do, because most often we will be discussing patients that have been treated and are in the follow-up. And so we will be able to review the outcome of our decisions and our approach and to improve them. And by doing that, we will go towards more and more standardized management protocols. Now, having a standardized protocol doesn't mean not to use your best instincts and fantasy, if that is the case, but it simply means that you motivate why you are diverging from the protocol, and you have a very rational reason in order to do that. And this is where innovation research lies. And this is where we recognize that certain areas are still gray, certain areas needs to grow, and needs to be studied and addressed in a scientific way, which means having controls, having group, using the different technology that we have developed in order to understand whether a treatment is for the benefit of the patient. We also, in the tumor board, is also open to external provider. They can call in and present their case. They can send the slides and participate and discuss, and they can do that through several digital ways, or even by phoning in. So it has benefits that are for the patient, are for the provider of the cancer center, but also goes beyond that, and really is helpful to the overall regional treatment of this cancer. So is this approach really helpful for the patient. Do we have data that show us that we are really improving their prognosis? And I would like to turn the microphone for a second to Tamar, because she's a co-author of this very interesting study that shows that for the first time that the patient discussed tumor board have a better prognosis.
Thanks, Mario. So this is a VA cohort, almost 4,000 patients. These are folks who were diagnosed with HCC between the years 2008 to 2010. And chart extraction was performed on every single case. So we actually identified 7,000 cases, and then after we reviewed 7,000 charts, we found those people who were actually diagnosed in the time frame of the study, that it was indeed HCC, that they were maintained in care longitudinally. And one of the variables that we looked at was whether they were discussed collectively in a forum like a tumor board. And what we found is that tumor boards actually do have a survival advantage. And it's not because the numbers of treatments were higher in those folks who were presented at tumor board. It was actually that the patient was assigned to the appropriate therapy, meaning that whatever therapy was assigned in tumor board resulted in prolonged survival. So if the patient was a child C patient and went on to palliative care, they may have survived longer than a patient who wasn't discussed in a tumor board and perhaps went on to TACE, which could have hastened their death. So again, it's really important to look at the quality of care, not necessarily the quantity of care. And this is really the first study in HCC that shows that tumor boards actually do have a survival benefit.
Yes, and this is a very important message. If you remember, in the first webinar, we showed you that having protocols for early diagnosis and oncologic surveillance in a patient at risk was improving survival. So this is phase 2. What do we do once we have identified the case, and how we can best serve the patient? So as we said earlier, this patient may come in from different referral lines, and depending on who is the specialist that received the referral, the patient may go through a different trajectory. And the way to make this sound and reproducible is to discuss them at the tumor board. So does the tumor board help? Yes, there are data that shows that physicians attending to tumor board weekly are more likely to enroll patients into clinical trial. Now let me discuss for a second the clinical trials. I mean, clinical trials are for the benefit of the patient. The ability to provide a clinical trial is improving patient care, because even if they are placebo controlled, the placebo is still the standard of care, and you will have the advantage of possibly having further and more advanced care before it goes into the market or common use. So it's a very important component of any program, the ability to have a sound and innovative clinical trial, and this is something that is clearly boosted by the tumor board. It's a gray area, because these are very care delivery studies, so understanding the effect and the consequence of tumor board discussion, it's not easy. I mean, it's also very much dependent on what methodology you use. So there are also studies that are contrary, but it is our experience of years and years of doing this that there's certainly a benefit. And in fact, there are data showing that the diagnostic workup or treatment plan is altered in more than 1/3 of the patients that are discussed in the multidisciplinary tumor board, for example, in the GI tumor board. This multidisciplinary approach will also help accruing something which is becoming more and more important in a modern care delivery, which is a measurement of outcomes, clinical outcomes, and more so patient-reported outcomes. This is a very important component. A patient-reported outcome is what the patient feel and is not altered by physician oversight. There are several surprises when you use this approach. Behind the tumor board, there is actually a full structure that helps organizing and scheduling and keeping the minute and keeping everything of time. And in our case, we're very grateful to our cancer center that provides all this support. Why do we need this? Because not only these tumors are very different from, and they're actually staged in a very different way, but also we have different treatments, and each treatment has a different, several indication and contraindication. So resection is the choice of therapy for patients that are not cirrhotic. When in patients are cirrhotic, you need to have a very good reserve. You need to have at least 100,000 platelets. You need to try to avoid major hepatectomy, and a few of them are actually eligible according to this indication. Now, surgeons are always trying to push the envelope a little bit on this, and so that's one outcome of the multidisciplinary discussion. Or sometimes the hepatologist is trying to push the surgeon to do something more. The ablation therapy, and local regional therapy, as I said, they are accounting for almost 50% of our treatments, and we are very grateful to our interventional radiologists who are mastering this approach. They're most effective with small tumors, and here there are very many modalities, and that clearly depends on where is the tumor located, how is its vascularization, and several nuances that are actually taken into account every time we discuss the case. Transplantation, it's the best treatment for HCC because cure both the cirrhosis and the cancer. But here there are several problems. Transplantation works on only early tumors. They have to be basically in the Milan criteria or be downstage to that criteria. But the problem is, as you all know, that unfortunately the liver, the graft available are not enough to really meet the needs here. Already in certain area, particularly in Europe, you can have like 40 to 50% of the cases being hepatocellular carcinoma in the transplant, but it's like sometimes empty the sea with a bucket. So these different approaches are associated with different survival, although you can see in the blue area, but you have to understand that also this survival is also driven by the stage. So it seems that resection is almost as effective as transplantation, but as a matter of fact, there are different patients. So resection of very early patient with more benign tumors, and transplantation is instead performed in patient which by definition their liver function is not allowing a resection. And the local regional treatment are often used to maintain the patient into the staging criteria for transplantation, and sometimes you may have a liver resection and then a transplantation. So there are several differences, and they're all analyzed during the tumor board. And if you then go on to the transarterial techniques, we're not going to go through all this slide, but it's just to show you how complex it is, how many different modalities we have, and how sometimes is difficult to personalize these approaches to the patient, but this is what we actually do because we put together all the components. Right. Also, if we more and more there are medical treatment available, I think this is a very good news. Is what we have witnessed it in the last few years, and to the initial single multi-tyrosine kinase inhibitor, sorafenib, was the only FDA-approved drug for several years. We now have regorafenib, we have levantinib, and more and more the immunotherapy compounds are knocking at the door, and they'll enter the scenario pretty soon. There are also a lot of dead trials, and you see how difficult it is, but it is important through the tumor board to try to look for more first-line treatment and second-line treatment. So having said this, I'm turning again the mic to Tamar for the case.
All right, so we are going to present this sort of as if I'm seeking counsel from Mario. So we're going to start with the first case. So this is a 60-year-old female with hep C and alcoholic cirrhosis. She's now abstinent of alcohol, and she does have portal hypertension. She has non-bleeding varices. She's had fluid retention in the past, but since she abstained from alcohol, that's gone away. She's had minimal HE in the past, now none. And she had an MRI that showed a 1.4 centimeter segment 8 mass. CT was done for correlation that showed a 1.1 centimeter hypervascular region in segment 8 that corresponded to the lesion seen on MRI. And it was small and a little bit equivocal. So the plan at the initial discussion was to do a surveillance MRI 6 months later. And that showed a stable 1.4 centimeter segment 8 mass consistent with HCC, LIRADS 5. So it enhanced, it washed out, and it had a pseudocapsule. And the patient was clinically stable over that 6 month period with platelet count of 111, INR 1.2, normal sodium, creatinine, albumin of 3.7, bilirubin a little above normal at 1.75, and an AFP of 17. So she was determined to be Child-Pugh class really A6, B7. If you look at her past history, it's always hard to stage a person in terms of their Child-Pugh score if they have had ascites in the past and then have gotten better. So she's almost recompensated in a way because she stopped drinking alcohol. Her MELD score is 11, and she is BCLC stage A3. So here is her imaging, an MRI and a CT. You can see her lesion here, and then you can see it again on the coronal sections. And this is 6 months later. This is an MRI that again shows this lesion, which enhances, it washes out. There's a suggestion of a pseudocapsule around it, and then on hepatobiliary phase, it again looks washed out as it should be on EOVIST. So I'm going to pose the questions to Mario. What would you do for this patient? Watch her, do a biopsy, resect, or ablate? And, really when you're thinking about this, should she be staged first before you touch her? Did she really need both the MRI and a CT scan? And what modality would you use for future imaging and why? And, because she has active hep C, should we offer her antiviral treatment? And if so, when? And maybe we should just refer her for transplant. So what are your thoughts?
Okay, so this patient has a lesion which is radiologically typical for HCC. It's called OPTN5A because this is it's one of the staging system, as Tamar said. But a patient with this appearance, meaning that there is a hyperenhancing lesion that washes out and a pseudocapsule, is actually with extreme probability an HCC if the patient has cirrhosis. So a biopsy can be forgo in this case. I would not watch it. The patient has a good function, but his bilirubin is high and the platelets are 90,000 or less. And okay, but there are viruses, and so it falls outside the indication for liver resection, and also will require a major right lobe resection. So in a patient with portal hypertension, that could be really dangerous. So the best approach here would be local regional treatment and specifically ablation, or if that cannot be done, a TACE. The role of staging chest and CT and bone scan, I would certainly do a chest CT on this patient. The bone scan may be done if the patient becomes of a transplant interest. MRI or CT, that's actually depend on the patient and how visible is the lesion. We tend to use more MRI than CT, but in a tumor like this, that's not really needed. And what modality you use for future imaging, that depends by how you started in order to have them comparable. And active HCV, that's a problem. Certainly active HCV needs to be treated. However, the current protocol and the current recommendation is to treat for HCV once you know that you have treated the tumor. So if you treat this tumor and 6 months after you see no recurrence, you'll be given them direct aging antiviral agents. I mean, this is still debatable, though. It's still a gray zone. There are several reasons to wait, several other reasons to get rid of the HCV while you're treating the patient. In this case, the patient is relatively compensated, so we may have the time to wait. And referral for transplantation, yes, these patients often are somehow put on hold for the transplant. I think given the limitation of liver transplantation in terms of number of patients and so on and so forth, it remains an indication only for patients that cannot be treated otherwise. But certainly, I would refer this patient also to the transplant team so that it can be worked up and listed in case the patient recurs.
Okay, so this patient has an HCC UNOS T1 lesion, BCLC A3, because she has portal hypertension and hyperbilirubinemia. It's a T1 lesion by UNOS. It's OPTN5A, meaning it's a single lesion under 2 centimeters. And so we discussed the merits and pitfalls of treating the lesion now versus watchful waiting, and she chose ablation with the hope of having antiviral therapy after ablation. She was also reassured that if she developed recurrence or a second lesion, she would be referred immediately for transplant evaluation. She responded well to ablation, and 6 months following ablation, she started DAA therapy and has since achieved SVR. She remains well compensated and recurrence-free. So that's a happy story. We like that story. Now, the next patient is a little bit more complex. This is a 55-year-old male with compensated Hep B and Hep C cirrhosis on tenofovir with an undetectable hepatitis B viral load. He was a prior non-responder to Hep C therapy, but is now considering DA therapy. And a pretreatment ultrasound shows the 3-centimeter mass in the right lobe. This actually is not an uncommon finding where a patient comes in to establish care for DA therapy and we find a mass. An MRI showed a 2.8 centimeter segment 7 lesion with rim enhancement on delayed post-contrast imaging. And the impression was that this was atypical. This was either peripheral intrahepatic cholangio, maybe a hypovascular HCC. His numbers actually looked excellent. So these numbers are the numbers that are consistent with a sort of normal human being, apart from maybe the INR of 1.1. So platelets over 150, everything else perfectly fine. So this is a child Pew class A5 patient with a MELD sodium of 7. And we deferred BCLC staging because we weren't entirely sure what we were dealing with. So you can see here, he has this tumor in a pretty ugly part of the liver. It's very hard to get to this for biopsy. You can see it here that it does look hypovascular in the arterial phase, the top 2 images, and it stays enhanced on the delayed phases, which is not typical of HCC. So in turning the question over to Mario, what would you do for patient 2? Would you biopsy him, resect him, ablate him, or perform TACE? And what's the role of staging? And what staging tests would you do? And would you advise surgery for resection without biopsy first? So are you convinced this is a malignancy?
In this case, we have a radiology which shows a mass, but without those typical features that we described earlier that can help us identifying this tumor as an HCC, bona fide HCC. This tumor, I do biopsy this masses, okay? Also because we are seeing more and more surprise in patients with liver cirrhosis that do not have this radiological feature of OPTN5.
So, yes, I think a purist would offer this patient a biopsy first, get a diagnosis, and then proceed to staging. In this particular case, this was a patient who was very difficult to bring in for follow-up, and we could not bring him in. He evaded our best techniques to get a person in for care, and ultimately the surgeon said, you know what, we all know it's a malignancy, let me just take him to the OR. And that is what happened. So about 3 months passed. He did get a chest CT and a bone scan prior to his surgery, and he underwent a partial hepatectomy. In the 3 months that passed between his diagnosis by imaging of a mass and his actual, pathologic diagnosis, his tumor grew to 5.1 centimeters, already not a good sign. Here you see the tumor in gross form, and you can see he has a very cirrhotic liver. So despite those beautiful labs, his liver is extremely cirrhotic. This is what it looks like close up. You can see it's really, a rather large tumor abutting the capsule. And on the background histology, you can see there is frank cirrhosis with nodular formation. It's more nicely shown in trichrome, but it's easy to see on the H&E. And here you look at the tumor, and it's a little odd looking. It seems like it has a central scar. It looks very heterogeneous. So this already looks a little odd. And then when we look at the tumor, we can see there is a stromal component, but actually it does look like an HCC. It looks like a poorly differentiated HCC. And then as we go on to other parts of the tumor, some parts have a very dense stromal component. Others have pseudoglandular formation in between, sort of wispy stroma. There's other areas that look like small cell change, and there are other areas that look frankly poorly differentiated. So this is a very bad acting tumor. Further stains were positive for MOC31 and CK1, which are seen more commonly in cholangiocarcinoma, whereas the arginase and HepAR stains, which are seen more commonly in HCC, were negative in these areas. And you can see that in other parts of the tumor, arginase was positive, but again, the features were really more supporting cholangiocarcinoma with some areas of HCC mixed in. So this was considered predominantly cholangiocarcinoma, 5.1 centimeter, segment 7-8, unfortunately with microvascular invasion. This was staged as a intrahepatic cholangiocarcinoma, stage T2A, N0, M0, stage 2. And he had, of course, background cirrhosis consistent with his chronic hep C. So the pathology was consistent with a mixed cholangiohepatoma, and vascular invasion was identified histologically. Margins were negative. He was staged and treated as cholangiocarcinoma. That means he got 6 months of gemcitabine and cisplatin. He was encouraged to continue on tenofovir for control of hepatitis B. In these cases, transplant is out of the question. We do not perform transplantation for mixed tumors. Because the tumor nearly doubled in under 3 months, from the time he was diagnosed by imaging and then taken to the OR, and with the vascular invasion, it suggested an aggressive course, and indeed he did have a very aggressive course. So I'm going to stop here. I have some questions that you can sort of look at over time. I can show them, or I'd rather take questions from the audience now, and if the audience is silent, then we can go ahead and tackle some of these questions. So if there are questions at this point, it would be great if people ask them now, and I can entertain them. All right, so with no questions, we're going to go over the questions that I prepared for you. So hepatocellular carcinoma, when we think about HCC, we talked about epidemiology in the first session. So it is the fastest rising cancer in the US. It is the leading cause of death in patients with cirrhosis, and it claims at this point probably closer to 850,000 lives per year across the globe. So all of the above suffice for this. The Milan criteria is defined by 1 lesion less than or equal to 5 centimeters, or up to 3 lesions, none more than 3 centimeters. And these other criteria are actually important criteria. So the 7 equals the sum of the largest tumor in centimeters, and number of tumors is the rule of 7, which is another way of looking at tumors. 1 lesion less than 6.5 centimeters, or total tumor burden less than 8 centimeters, is the definition of the UCSF criteria. And 1 lesion less than 10 centimeters without vascular invasion is a T1 lesion, believe it or not, by other staging classifications. And in many patients without cirrhosis who present with tumors like this, actually surgery is indicated.
Excuse me, Tamar?
Mm-hmm.
We're going to have to wrap up shortly. I'm sorry to interrupt you. Is that okay?
Yeah, that's fine. So I'm gonna, I have another slide on questions, or we can just wrap up right now if that's what you'd like to do.
I think we probably need to wrap up. I'm sorry.
Okay, no problem. So Donna, you can take it away with the conclusion.
Okay. I'm getting to it right here. There we go. Okay. So I just wanted to thank everyone for participating this evening. I just want to share with you some of the website resources that we have. This was a recorded webinar, so you can access this on the ALF Connecticut website. The Connecticut website is www.liverfoundation.org/Connecticut. The national website is liverfoundation.org. We have a national helpline, 1-800-GO-LIVER, which is 1-800-465-4837. We have several resources online for educational materials, as well as the drug discount card. We do definitely want to thank Dr. Taddy and Dr. Strazabasco for contributing to this program. They did a wonderful job. Their expertise is amazing. And we also want to acknowledge and thank Bayer, who made this webinar possible with a generous grant. Thank you all so much.